We often prescribe diuretics to manage oliguria in a patient with chronic kidney disease, but when it comes to a patient with intrinsic acute renal injury, we quickly resort to hemodialysis if a trial of diuretic challenge fails. Why is it so? Why can't we prescribe more of diuretics similar to what we do in a patient with chronic kidney disease? Because in a patient with acute kidney injury, there would be tubular epithelial cell damage. It is that tubular epithelial cells which are going to secrete the diuretic into the tubular lumen via the organic anion transporter. Because these cells had incurred an injury, the transport of diuretic across these cells into their site of action cannot properly take place. Also, owing to the injury, there would be loss of adhesion among the tight junctions of the tubular epithelial cells. So this would lead to backfiltration of the fluid in the tubular lumen into the renal interstitium, thereby reducing urinary output. Also, in severe cases, the tubular epithelial cells would slough off from their basement membrane into the tubular lumen and cause mechanical tubular obstruction. This further obstructs the oncoming urinary fluid and increases the pressure inside the Bowman's capsule. This would lead to a reduction in GFR. So, if a trial of diuretic challenge fails, adding additional dosage of diuretic in a patient with intrinsic AKI would not help much. The disease would go on in its natural course to repair itself and regenerate the lost tubular epithelial cells. And only after that, urinary fluid can eventually pass into the terminal collecting system. So, when a patient with acute kidney injury goes into oliguria, do not push much of diuretic expecting a response. Instead, take over its function with hemodialysis and let the body to repair itself to function again properly.